Thanks for listening to the Pharmacy Podcast Network.
Hello, everyone, and welcome to the Geriatric Pharmacy Focus. I am blessed to have back with me today Dr. Diana Isaacs, host of the Diabetes Dialogue podcast and known as the Diabetes Pharmacist. And in December, the American Diabetes Association came out with the Standards of Care in Diabetes 2026. So we are going to be discussing that today, just kind of some updates, management of diabetes in our older adults, and anything where I guess the conversation takes us. So welcome back, Dr. Isaacs. It's great to have you with us.
Awesome. Yeah, thank you so much for having me again.
Yeah, so when I was reading through the update, I was most excited about kind of the whole person centered view of this update, where we weren't just looking at which medications have benefit for cardiovascular disease and things like that, which are, of course, so important, but also addressing diabetes distress and anxiety associated with diabetes, the language to use for people with diabetes, how to manage religious fasting for those with diabetes, the 4Ms framework. So that was my big takeaway with this update is we're looking at the whole person, not just medications and managing different disease states associated with diabetes, but whole person care. I'm curious to know what your big takeaway was when looking at the update.
Yeah, well, I agree with everything that you've said. And I think they've really made an effort to be more person centered. And you can see that with the language. It's taken a few years, I think, to really incorporate this because I was on the committee from, I'm trying to think, it was like 2020 to 2023. And I know during that time, like we were trying to change patient to person and but it takes a while to really, it's a long document. It's over 300 pages and it takes a while. And I feel like with this round, they really did a very good job with that, with all the recommendations and the narrative text as well. One of the things I was especially excited about this year was the technology updates, and especially with both CGM and insulin pumps and automated insulin delivery. I think the encouragement of using CGM really for all people with diabetes, but certainly those on insulin. And we see now CGM being mentioned really in almost all of the sections. Before it was just in the technology, but now whether it's the pharmacologic management, the older adults, like it's really, it's mentioned everywhere. And then also with pumps, really a strong recommendation that we should be offering automated insulin delivery systems for anyone that needs mealtime insulin. And yes, this also applies to older adults too that can safely manage the system either by themselves or with a caregiver. But I think, it's obvious that we have the data to support that technology improves outcomes compared to asking someone to inject 4 times a day or more. That's very difficult. So I was very excited about that. And then also there's some updates, I think, with the pharmacologic therapy. So lots of good stuff this year.
It was so good. I haven't had a chance to read through the document in its entirety, but of course, section 13 on older adults I did, and then reading just different cliff notes and places where people listed key points of the updates. And I agree with using technology. I was just speaking with an older adult the other day. I had called at the retail pharmacy and we were discussing his CGM and how much he liked it. And then we were discussing insulin and talking about those mealtime doses. And he's like, I just can't get myself to do it. I don't know why. There's my pen sitting there and I should do it. I just don't want to. And I can't motivate myself to do it. And I said, well, have you ever thought about an insulin pump? Then you could fill it up and you could just let the pump do its job, or you could simply use your, smartphone to give yourself a mealtime dose. And he said he hadn't ever thought of it. And we got him started on some Omnipods, and he I mean, his A1C has dropped and he's so happy. He just didn't know what it was, if it was giving himself all those injections or what it was. But suddenly with this Omnipod, it's like no big deal. So let's
Yeah,
use it. Yeah.
it is really hard to do multiple injections a day. Like there's multiple barriers. Some of it is just the psychological of like, oh my gosh, I'm another needle going into my skin, but also like gathering of all the supplies. So yeah, something like Omnipod, which now, it's in the pharmacies, that has helped a lot of people. There's also, they make mention of other wearable types. So like, for example, there's Secure Simplicity, which is basically, they consider that like a wearable insulin. It doesn't have like the sophisticated smart technology where it's got a bolus calculator and it's connected to your CGM. But what it does do is you wear it and you click the sides of it and you can easily give a bolus without having to get your pen and needle out, and you can do it over your clothes. So there are a lot of tools out there and that are mentioned in our standards of care.
Yeah, absolutely. I'm thankful for that and thankful more people are using them. So there's also a focus on monitoring blood sugars in patients taking medications that may cause hyperglycemia. They mentioned corticosteroids, different chemotherapies, but can you elaborate on, as far as the guidelines go, how we're supposed to monitor patients that are on medications that may cause hyperglycemia and then the management of those patients?
Yeah, so they do now, like, especially in section 2, they've really kind of beefed up where they're talking about these different medications that could potentially impact glucose levels and how we should be monitoring them. We should be, whether it's checking fasting glucose, asking someone to monitor, wearing a CGM, like doing a trial of CGM to see if they're starting to have some glucose abnormalities. And there's certain medications like checkpoint inhibitors, like glucocorticoids, that we know, like a lot of like cancer agents, that we know impact glucose levels. And so we really should be monitoring. And then they also have guidance in terms of what that treatment could look like, depending on the type of agent that's being used, whether it would be encouraging the use of insulin or encouraging other types of medications. But I think that was definitely added this year with more emphasis, because you figure a lot of times whoever's adding those agents, they're not focused on diabetes necessarily, right? Like if someone's going to an oncologist, they're trying to cure the cancer. They're not, diabetes is not their first priority. But we hope the cancer will be cured or they'll be in remission. And so we do care about the diabetes. We do care about the hyperglycemia, which could lead to certainly acute complications like dehydration, electrolyte abnormalities, but also increases someone's cardiovascular risk as well.
I've noticed it in older adults, mostly people with arthritis or some kind of autoimmune might be on a steroid long term. So I notice it that way. Or are older adults on antipsychotic medications long term? I see their blood sugars going up. And so oftentimes they're put on metformin, or now more recently, they're put on GLP-1s to help manage those kind of side effects associated with antipsychotic medications.
Yeah. And I think it's important. So sometimes, so I do a lot with our post kidney transplant clinic, and they're only in the hospital usually for a couple days. So many times, like steroid induced diabetes will be caught in the hospital, but not always. Sometimes people don't have elevations until a few weeks later, and they're typically only checking fasting glucose. And so, yes, fasting glucose will eventually be impacted if someone has enough hyperglycemia, but it's often going to be the last thing to be impacted. They're going to, if someone's taking, for example, prednisone in the morning, we're more likely to see very high glucose levels throughout the day. And so that's some of the reason why monitoring can be very helpful, because someone, maybe they wake up, their fasting is in the low 100s, so no one's really too worried about it, but they're going up to like 300, 400 during the day. That's not good.
Yeah. And, if you watch it close enough, they'll probably be more thirsty, going to the bathroom more. But our older adults are tricky because, you know what? They're not very thirsty sometimes. And,
Yeah, and people attribute it to they're like,
uh-huh.
oh, well, now that I think about it, I'm more thirsty, but I don't know. I just thought it was this other medication. Or like they don't always have the insight to say, oh,
Mhm.
like that these are new symptoms, or maybe I have a high blood sugar.
Right. Or even if there's cognitive impairment there, that makes things even a little more tricky.
Definitely.
So in section 13, when it talks about older adults, of course, that's what I want to focus on today because this is the Geriatric Pharmacy Focus podcast. I was excited to see the 4Ms framework listed, and it lists the 4Ms. So, of course, medications, mobility, mentation, and what matters most. And talking about incorporating the 4Ms into our practice in managing persons with diabetes. And so it talks about, first of all, medications, which we know, avoid hypoglycemia is a big priority for us, but also treatment burden when looking at multiple injections a day, looking at polypharmacy, which I was very happy was mentioned because so many older adults have polypharmacy. So that's kind of a few things that mentions with medications. With mobility, it mentions foot complications. Are we monitoring to make sure they have sensation in their feet? Functional abilities, frailty and sarcopenia, which I was happy that was mentioned with GLPs in our older adults. Gait imbalance and dizziness, neuropathy, and vision and hearing impairment. Then mentation, it mentions the ability to self-administer medications, the ability to use the diabetes technology that we have. Anxiety, depression, and diabetes distress, which seems to be a more of a focus with this update, cognitive impairment and dementia, and then coping skills and self-care. And then, of course, what matters most, discussing goals with our patients and expectations, the disease burden of diabetes and symptoms, meal and treatment preferences, risks, burdens, and benefits of treatment, loneliness, social isolation, and overall quality of life, and then life expectancy. So when you think about those 4Ms, how do you incorporate those into your practice when you're dealing with older adults?
Well, I want to say I love this 4Ms approach, and the diagram like included in the standards of care is really nice. Those visuals are really good because it's like in practice, it's much quicker to look at these visuals and be like, oh yeah, the 4Ms, versus just reading a bunch of text. So one of the things I really like is they have a table that they've added about quick screening tools that can be used. And they list several of them that are for all these kind of related conditions. And what I really like is that they say what the time is to complete them. And most of these, they're designed to be screening. So if someone screens positive, you would ideally refer for a more lengthy assessment, but they're like 1 to 2 minutes, these different screeners. So I think the goal is these different areas, like for example, there's depression, the falls or risk of falling, frailty, malnutrition, pain, polypharmacy, sarcopenia, sensory impairment. You'd be assessing for these at least every year. And so you could, with these being 1 to 2 minute assessments, I think it's easy to incorporate, if you're seeing someone every 3 months, for example, to be able to incorporate some of these different assessment tools into a busy practice. And there are more than just these listed, but I think it's really nice for someone trying to start to incorporate this. Because I think the thing is, we are all seeing older adults. Like the other thing that they mention now is that, I mean, people fortunately are living longer. There's so many more people than ever with type 2 diabetes. The chapter actually opens off that 29% of people over the age of 65 have diabetes. And obviously, so most of those cases are type 2 diabetes. However, people with type 1 diabetes are now living much longer thanks to better therapies and technologies. And so this is kind of the first time ever that we now have several people that are older that are living with type 1 diabetes. And so this creates kind of a whole new world of, oh, well, how do we manage that? Many of them are on pumps, and what happens with those pumps when they transition, if they're in a home, like who can manage it for them? So all that to say is that this really important to incorporate these assessments into our practice. Also, I just want to say, like regarding the medications, I think they've done a very good job of talking about, okay, what should we be looking for? Like, what are the glucose goals and when can we back off? And how should we back off? So there's actually a very nice like diagram of, all right, let's say someone's on mealtime insulin. how are you going to try to like wean them off? And in type 2 diabetes, typically we're trying to get them off of the mealtime, the prandial insulin, but we would keep the basal. And then can we actually transition to non-insulin agents and ones that don't cause hypoglycemia, ideally? So I think this info is going to be really, really helpful for clinicians because we're all like, whether you work in this area or not, like we're all seeing people over the age of 65. And there's also wide differences in people over 65. So some are like healthy, very, very healthy, right? Probably we expect them to live several years longer. And then others are more frail, and the way we treat them is going to be a little different.
One of the 4 M's I think I overlooked initially was what matters most, because sometimes you look at a patient's medications in their med list and you think, oh, I got to get them off that med. But that might be a medication that they have had really good luck with and have really liked, and they don't want to go off that medication. Or maybe what matters to me is, yeah, getting them off mealtime insulin, but that doesn't matter to them. So that's one thing I really overlooked in the beginning, and now is like, to me, the most important of the 4 M's.
I totally agree with you. I think starting with that is really, really important. I had a patient yesterday who very lots of comorbidities, like significant cardiac issues, wheelchair bound, like very, very, very sick. And he comes in with his wife, and his wife is like, his problem is he eats too much chocolate. He like he just he I bought these Hershey Kisses and he's eating the Hershey Kisses and like, and it's like, well, wait a second. Like, let's ask him. I mean, if he enjoys the chocolate, like let the guy have some chocolate. So anyway, we talked about, hey, is there a way to we can incorporate some Hershey Kisses into our lives, but
That's right.
still regulate the glucose around them. So I think that is very important. And also, like, keeping in mind, there's a lot of like depression, diabetes distress. Those are issues I see a lot. And if those aren't addressed, you could have the best medication regimen ever, but it's not going to mean anything. The person may not be motivated to do the self-care behaviors.
That's right. I have seen the diabetes distress in both, persons with diabetes and their caregivers. I see parents or caregivers that are so concerned, they're going to be on a road trip and the pump is going to fail. So they come to the pharmacy to get a box of insulin pens just in case the pump fails while they're gone. And you see just the people who carry fruit snacks and juice boxes with them wherever they go, even if it's a walk around the block. And it does make such a big impact on patient lives when there is that fear or anxiety around having diabetes.
Definitely.
So the 4 M's I love, you mentioned those screening approaches, and I do love those too. Those are also in section 13. And it's just different screening approaches for geriatric syndromes. So I'm going to read a few of these screening questions for people who have not had the chance to go read these. So, for example, the screening question for cognitive impairment is, have you noticed any changes in your memory or ability to think clearly? To screen for delirium, what day of the week is it? You can ask. To screen for depression, during the past month, have you often been bothered by feeling down, depressed, or hopeless? To screen for falls, have you fallen in the past year, or are you afraid of falling due to balance or walking problems? For frailty, have you felt unusually tired recently or had difficulty walking up steps without resting? To screen for malnutrition, have you unintentionally lost weight? To screen for pain, simply ask, are you experiencing any pain? And so there's about, 7 to 10 more of these just simple questions you can ask to screen. But I love these screening questions because, yeah, if they're starting to have cognitive impairment, let's catch it now. Do they need their hearing checked? Or are there anticholinergic medications that could be deprescribed? So I think these screening tools are so good to try to prevent the falls, prevent having patients with depression that are untreated, having pain that's untreated, and just care for the overall person.
Yeah, I completely agree. The other thing, those, and I like love that they listed all these different screening tools, especially like sample questions, and then the fact that they are really short and seem like they'd be very easy to implement into practice. The other thing that I do is I'm big into demonstration. And if someone's like time in range, their glucose has changed recently, I want them to show me like, hey, can you show me how you use this insulin pen, like how you dial it, how you would give it. Let's see how you fill your insulin pump. Because that way you can catch if there's issues, like sometimes the visual, like they're just not able to see the way that they were before, or they don't have the dexterity to be able to use the devices. I think the other thing is incorporating like who in their life can help. Because just because someone loses dexterity or loses the visual, um, if as long as they have someone in their life that can help, then we can still use all the things. But I think that support is really important with aging. Unfortunately, not everyone has that support. I think if they can, like my patients can bring someone with them to the visit to hear everything that we're saying and reinforce it and help at home. But not everyone has that. And I think that's a really important thing that we should stress with aging. Having a support system, having some help on standby is needed.
Agree. Even in the standards of care, it mentions too just education for even the long-term care facilities to educate staff on how to use CGMs, how to use insulin pumps. So that education for people taking care of our patients is huge.
Yes, it really is. And I would love to see them get more comfortable with CGM, ideally with insulin pumps as well, because we don't want to have to stop technology just because someone's going into a long-term care
Yeah.
facility.
I think the biggest barrier of CGMs in long term care facilities, and I'm talking specifically skilled nursing facilities, is that there's a regulation that skilled nursing facilities are required to pay for all diabetic testing supplies. Well, that makes it really unfeasible to use CGMs in skilled nursing facilities if they have to pay for all the CGMs for their residents. So I'm not sure, and I could be wrong about this, but I'm not sure how widely CGMs will be used in skilled nursing facilities until we can start billing those CGMs to Medicare instead of to the skilled nursing facility.
Yeah, that seems like it's a problem, but at the same time, CGM is really not that much more expensive than testing supplies.
Okay.
The price has come down quite a bit that I bet they could work out some deal where I don't think the cost would be so much. Now, insulin pumps are a bit more money, but CGM is really, with them all being disposable now, has really come down in price. And when you think about the potential to reduce severe hypoglycemia events, to probably reduce DKA, hospital admissions, I would think even if there is a slight extra cost, it would be very, very worth it. So I hope they can figure that out because I think it would benefit everyone to do that.
Agree. And even to cut down on nursing time.
Yes, and it would help me because I have some patients in these homes that I'm still trying to manage. And the communication is very hard since I don't work in these homes, and I'll meet with them for like a virtual visit, and they're like, "Oh, well, I don't know what insulin they're giving me, or I don't know, I'm not sure where my readings are." And then maybe a couple days later, somebody faxes the readings to me, and then I'm like hunting down for information. I'm like, I just can't get an answer, and I don't know if the insulin's even given on time. Like, is it given before they eat? Is it given after? Like, there's just so many questions. And if they were wearing CGM, at least I could pair it up with our system and at
Yeah.
least have all that glucose data. So that would really be very, very helpful for communication.
Agree. There's got to be something that changes because now it does. It seems like these patients are getting such great care. They've got their CGM, they're being well managed. Someone's looking over their Dexcom Clarity or whatever data we have from these CGMs. And then it's like they go into these skilled nursing facilities and all of a sudden it all stops and we're taking the CGM off and going to finger pokes and then the data is lost. So I agree with you that hopefully in the future, I wish someone would do a study on, cost and benefit and just show the benefit of continuing to use CGMs, even if the skilled nursing facility has to pay for them. But I know they're on tight budgets too. And I guess I don't know all the answers, but I hope that's coming one day where we continue to incorporate CGMs for all of our patients. Okay, so let's get into medications. And in section 13, it does go over pharmacologic therapy and kind of little pearls for our older adults. So let's start with metformin. It lists metformin in some of the benefits, of course, low risk for hypoglycemia. It does a nice job, lowering A1C. It's easy to administer. Some of the cons, right? GI side effects, which we do see less with our ER formulations. Although if a patient's getting their meds crushed, that's not feasible either. Renal dosing. So you got to watch for renal impairment, and then monitor B12 levels annually after they've been on the medication for 4 years. But I still really like metformin. I don't know what your thoughts are on metformin in our older adults.
So I like metformin too. And it's so interesting because you hear like kind of a school of thought of like, oh, well, I'm trying to get everyone on SGLT2 inhibitors and GLP-1s, and we're taking away the metformin. But the thing is, when someone's lived with diabetes for so many years, they often they need more. they often need multiple medications to manage and get to those glucose targets. And metformin is a great drug that it's very, very effective. It's very safe. And so, yes, I like metformin as well. I think the biggest probably concern in older adults is just the GFR cutoffs. And so we don't use it. We don't start it if the eGFR is below 45. And then if someone is already on it, we can continue. But typically we don't use more than 500 milligrams twice a day or 1,000 milligrams extended release once a day. And then when the GFR, if it goes below 30, we do discontinue. And that's just because we worry about the accumulation in the body, which in theory could put someone at higher risk of more side effects, and potentially lactic acidosis is the big one, although very, very rare. But otherwise, if someone's kidney function, if it's within those thresholds, it is a great option to use. And I think I'm also glad that they mentioned the B12 and specifically the 4-year call out, because I think people were like initially confused. They're like, when do we monitor? But now having that exact guidance, I think is very helpful. And I think the B12 is very important because being deficient in B12 can cause memory issues. It can cause neuropathy, like all things we don't want in our older adults. So I think that is good. And we can supplement with B12 if needed as well, if someone's levels start to go lower.
Yeah, I was happy about the B12 too, because most of our older adults are also on a proton pump inhibitor. So I do think the combination of those two can really plummet B12 levels. When my patients get into a nursing home, I don't always know how long they've been on metformin, so I just monitor yearly. But it was nice they included the 4 years as a marker when to start monitoring. So the next up is pioglitazone, which I really happen to like pioglitazone as well because it's good for insulin resistance, right? And so, of course, we have to use caution for our patients with heart failure, fluid retention, monitor weight gain. I listened to a podcast recently on Peter Attia's podcast. It was a diabetes episode. They kind of mentioned that pioglitazone-induced weight gain is more from the movement of fat from the organs to more subcutaneous. So it wasn't necessarily a bad thing. What are your thoughts on that?
No, that is true, right? It's moving the fat to the healthier places. So the weight gain in itself isn't necessarily a concern in of itself. The other thing is we're sometimes worried, like with our older adults, we don't want them to lose more weight. And that sometimes is a barrier with GLP-1 drugs because we don't actually want them to lose weight. So therefore, the weight gain in of itself isn't always an issue, but there are some other things with pioglitazone that, some concerns. So it can, there is a higher risk of osteoporosis, which isn't great in an older adult. As well. And then fluid retention. So we really have to watch out if someone has heart failure, we're not going to use this agent. But there are also other benefits as well. So in addition to like improving the insulin resistance, there's also positive benefits on stroke. So if someone had a stroke, that it can be a good agent to use. And then also for liver health, so for MASLD and MASH, it has benefit probably because of how it's redistributing the fat and taking it away from the liver to other areas. And so I think in the right circumstances, it can be a good drug to use. You just have to weigh kind of the pros and cons and decide for the individual, is this going to be a good choice or not?
Absolutely. The next one is one I'm not a fan of, and that's the sulfonylureas, just because of that high risk for hypoglycemia, risk for bone loss and fractures. And then, of course, the pros would be that they're very inexpensive and they're oral, so you don't have to do injections. But thoughts on sulfonylureas? Do you ever use them?
Well, yeah, unfortunately we do. We're trying, they've really fallen out of favor a lot because of their risk of hypoglycemia, and especially unpredictable hypoglycemia. Because it's like if someone doesn't eat or there's some change that's happened, it increases the risk. We never want to use glyburide in an older adult. And I would say we just try not to use glyburide. Usually if we're using a sulfonylurea, it's going to be glipizide or glimepiride. I just think there's some situations where we still end up using it. It is a generic, super cheap medication. And if someone is just they're having a lot of hyperglycemia and we're not able to get another drug, sometimes this is something that can quickly resolve the hyperglycemia, but just definitely not one of our preferred agents because of the hypoglycemia. And there's also no cardiovascular benefit either.
Right.
And there can be weight gain as well.
Yeah. And the glyburide, the reason that's the highest risk is it's the longest acting, right? So the highest risk for hypoglycemia.
Right. And interestingly, one of the things they call out in this section is the drug interaction with fluoroquinolones,
yes,
as well as Bactrim, that they can increase the amount of sulfonylurea. So basically they can increase hypoglycemia. So I think that's important drug interaction to also be aware of.
Yeah, unfortunately, one that I think gets clicked through or kind of ignored, but can be a major issue when you look at what can result as a result of hypoglycemia.
Right.
So the next one is the DPP-4 inhibitors, which aren't really my favorite anymore. I don't know what your thoughts are. They are well tolerated, few side effects. I don't see a large, decrease in A1C or a large glucose lowering effect from them, but minimal risk for hypoglycemia. Linagliptin is kind of nice because it doesn't require renal adjustment if you have that patient that has low kidney function, has to come off metformin, and doesn't want an injection or anything like that. Another thing with the DPP-4 is no, reduction of cardiovascular kidney disease either.
Right. So they are neutral for their cardiovascular kidney impact. And actually, saxagliptin in allogliptin showed increased heart failure hospitalization. So there's some concern on those two specific DPP-4 inhibitors and heart failure. But they can be good agents to use if you just need a little bit of glucose lowering, because they're very well tolerated. So especially if you're concerned about weight gain or weight loss, these are going to be weight neutral. And so if someone just has a little bit of glucose lowering that's needed, these can be great to use. They're also just like it's a once a day pill. So I think there's definitely circumstances, probably older adults is the time where I'm more likely to use this class of agents, because otherwise I'd say really GLP-1 drugs have taken over and we're using so much less of these. But I think that this is a nice tool to have in the older adults where you get some glucose lowering in a very safe way.
Yeah. Another side note is there's no reason to be on a DPP-4 inhibitor with a GLP-1 based therapy.
Correct. Yes. And the guidelines do say that in section 9 with the pharmacologic therapy, you don't want to have both of them. In theory, there is a chance it could increase side effects, but also it's really just a waste of money and taking an extra medication when there's a huge duplication in their mechanisms.
So next are the GLP-1 based therapies, of course, really kind of blew the market out of the water when it comes to managing diabetes because they are highly effective. It's nice that most, are just once a week, low risk for hypoglycemia. You can use them with a reduced EGFR, even for patients with dialysis. They have cardiovascular and chronic kidney disease benefit. But they're not perfect. We have those GI effects, and for our long-term care or geriatric patients that already have constipation, or maybe difficulty getting enough nutrition in. That can be a problem. And then the muscle loss or sarcopenia is a concern for me, especially just because when I look at my older adults in especially skilled nursing facilities, they're not getting a lot of protein. It's a very carbohydrate heavy diet, so the protein intake is a worry for me. And then also the strength training, if they're in therapy, great, but a lot of them aren't. So then that's a concern as well.
Yeah, so you're absolutely right. I mean, these drugs have taken the world by storm. They are very effective at glucose lowering and for weight loss. And then we're discovering all these other benefits that they have too, like with MASH and MASLD, with sleep apnea, kidney disease, heart failure with preserved ejection fraction, cardiovascular disease, even osteoarthritis, and even there's other conditions they're still exploring that may have benefit. So we often want to be able to use these if we can, but we do need to be very, very careful on the GI side effects, which it can actually be constipation or diarrhea. So we have to watch out for that. And definitely nausea. And then the food intake. So some people are very, very affected and find that they're not eating, they may not be drinking, so they could get dehydrated. That actually could put someone at risk of acute kidney injury if they're having all these GI side effects and they're dehydrated. So there are some real risks here. One of the recommendations that comes from the guidelines is about getting enough protein to avoid sarcopenia, and they recommend at least zero 0.8 units per kilogram per day. And so I think ideally having someone work with a dietitian, diabetes educator, work with someone to come up with a meal plan that incorporates a lot of protein choices. And then also the strength training is so, so important. And it doesn't have to be it doesn't have to be going to Orange Theory. It can be like chair exercises, right? Like, or dumbbells like that you're doing from the chair, or getting, seated to standing up. There's a lot of exercises. If someone can learn these exercises, either through working with an exercise physiologist, if you have that luxury, or physical therapy. But most people, even if they have a lot of physical limitations, we can come up with some type of exercise to strengthen the muscles. And that's going to be so, so important to be able to, continue, be able to use these medications long term.
Yeah. What I love about this is I think all of our older adults, regardless if they're on a GLP-1 based therapy or not, could use probably more protein and more strength training. So it's been good to put more emphasis on both of these things. Of course, it always mentions using a GLP-1 based therapy with proven cardiovascular and chronic kidney disease benefit. Which of our GLP-1 based therapies do have those benefits? It's not all of them?
It is not all of them, but it is most of them. So interestingly, exenatide looks like it's exiting the market. And in fact, they have a list in section 9 of like all the different medications. They took it out of the algorithm and they don't even list the pricing anymore. So I think we're going to see that go away. But that was one that was kind of neutral. The data showed it was neutral. But dulaglutide, Trulicity, has the cardiovascular benefit. So does liraglutide. And liraglutide is a generic. So even though it's a daily GLP-1, we're sometimes seeing more of its use because it is lower cost. And then our kind of our two big guns, semaglutide or Ozempic, it has a lot of indication. It has the cardiovascular indication, it has the kidney disease indication. And then for the obesity version, the Wegovy, it also has the MASH indication as well. And then it's shown positive data for heart failure with preserved ejection fraction. Tirzepatide is our other big gun, and that one's unique in that it's a GLP-1 GIP agonist. and Mounjaro for the diabetes version, or Zepbound for the weight loss version. The Zepbound has the sleep apnea indication. So Mounjaro does not have a cardiovascular indication, but they recently published the SURPASS CVOT trial. And that trial showed that it was non-inferior to dulaglutide, which does have a cardiovascular indication. And then there were trends toward improvements like less mortality, less cardiovascular events. It just wasn't statistically significant to reach superiority. So we'll see how the FDA responds to that. I can tell you our cardiologists very much think, okay, it's got a cardiovascular benefit, and they feel very comfortable using it. It's just depending how a drug was studied, it has different indications. And then one of the other things is there is the oral semaglutide as well as Rybelsus, and that has a cardiovascular indication as well. And also very recently, the oral Wegovy, so the high dose oral semaglutide, it goes up to 25 milligrams. That just became available and it's in pharmacies now. And that actually has a cardiovascular indication as well, because of the fact that Wegovy was studied in a population of obesity and showed a 20% reduction in the 3-point MACE, the major adverse cardiovascular events. And then I think because Rybelsus also has this indication, that they also granted this indication for the oral Wegovy as well. So it's very interesting, this whole world. The indications keep growing, but I would say most of them have very positive data. The one exception is, which you probably don't see this that often, is lixisenatide. So that is a daily GLP-1, but it's not available as a standalone. It comes it's called Soliqua. It comes in combination with insulin glargine. So sometimes we'll see people on that because of the convenience of a once a day. And also it's one copay instead of two. So you're combining that GLP-1 with the long-acting insulin. But that one, lixisenatide, was studied and it was non-inferior, but it had no cardiovascular benefit. So it does seem like there is a little bit of a difference between the type of molecule. So we can't assume any GLP-1 drug would have the cardiovascular benefit, but it does seem that so far most of them do.
I'll be curious to see, in 2026, how many prescriptions we get for the oral versions, because so far it's been minimal, I would say.
Well, it just literally became available on January 5th, and for the oral Wegovy, and there is supposed to be like you can order it directly through Novo for $149, and I think there's GoodRx coupons, like you get the first couple months for $149, then it goes up to $199. So that cost is significantly cheaper than what our injectables have been for those that don't have insurance coverage for it. So it will be really interesting. Now, I agree with you, Rybelsus, which has been out for years, has not really taken off in the way that we would have expected it to, maybe. And I think what we're learning is people are like, oh, a weekly injection is not so bad.
Yeah.
So for the most part, people are choosing that. Also, the thing with the oral semaglutide is it does need to be taken in a very special way. So empty stomach, maximum 4 ounces of water, no coffee, no other pills. You have to wait at least 30 minutes to take your other pills. And I think in talking to people about this is very inconvenient because people wake up, they want to have their coffee right away. They need to take their other pills. They don't want to have to wait or afraid they'll forget to take their other ones. So it is not the easiest drug to take. Now, there is supposed to be an oral non-peptide GLP-1 coming out this year called orforglipron. And that one would not require any special way of taking it. It could just be taken with all the other pills. So that we might start to see greater uptake in that when that comes out. So we'll see.
Very interesting. Can't wait. All right. So the next class of medications is our SGLT2 inhibitors, which have been shown beneficial for heart failure and also chronic kidney disease. Well tolerated from what I've seen. The things we should, be cautious of is volume depletion in our older adults, and then monitoring for infections, UTIs. But benefit, well tolerated, oral once a day seems to be a nice addition to our diabetes repertoire, I would say.
Yeah, and the benefits for kidney disease, for heart failure, and in fact, it's used a lot for those conditions, irrespective of having diabetes. I think things to keep in mind are that if the GFR is below 45, you're going to have very minimal impact on glucose levels because you need the flow for it to be effective for reducing glucose. So if you're trying to use it for glucose lowering, not going to work, but still a great drug to use for that kidney function, that kidney disease. And then the other thing is that if someone's glucose levels are higher, they're definitely be at greater risk of those infections. If someone is taking insulin, they're also greater risk of the euglycemic DKA, DKA where glucose doesn't get as high. And so those are, some of the things we worry a little bit about that we just need to use some caution with.
Yeah. And not all the SGLT2 inhibitors have benefit for heart failure and chronic kidney disease, but most. Is that true?
Yeah, it appears that they all have benefit for heart failure. Well, I should take that back because bexicagliflozin, the drug, the SGLT2 inhibitor that was originally approved in cats that then gained the human approval, that doesn't have any data supporting any cardiovascular benefits. So there's just not data. So anyway, that one doesn't, but all the other ones do. But really, canagliflozin, empagliflozin, and dapagliflozin are the three big guns that have the most evidence. Like they all have evidence for kidney disease, for heart failure, for cardiovascular benefit. So those are going to be our three big ones. There's also ertugliflozin, but that one, it was very disappointing, the results. It did have benefit for heart failure, but not for cardiovascular disease or kidney disease. And then there's also sotagliflozin, which is really a heart failure drug. So it's not always listed as like a diabetes drug, but you could use it for people with diabetes. And it has the SGLT2 and 2 inhibitor, but it definitely has the heart failure benefit and the cardiovascular benefits.
So monitor EGFRs for patients on these. And then remind me, is there a certain cutoff point where you have to discontinue them or you just won't get the blood, glucose lowering if it goes lower?
Yeah, you just won't get it. I mean, I think usually once somebody is on dialysis, we don't necessarily continue it. I'd have to check though, because the labels keep changing.
Yeah, they do.
You can use it really through end-stage renal disease. Like they have benefits and you can be monitoring albuminuria and certainly monitoring the GFR. But yeah, once it's below 45 and definitely when it's below 30, you're just not going to expect to see the glucose lowering benefits.
Got it. And last but not least is our insulin therapy. And it does mention for older adults, a once daily basal insulin is a reasonable option without doing a mealtime insulin. But it also does mention that, we don't want to have complex regimens for our older adults and that non-insulin therapies are preferred due to lower risk of hypoglycemia and then the potential cardiovascular and chronic kidney disease benefits.
Yeah. So I think insulin is it has so many risks of hypoglycemia, and insulin's a drug with a very narrow therapeutic window. So it's hard to dose it and get the glucose within target. But I think what you have to keep in mind is like, what are the goals? And there's a nice table that kind of illustrates what the goals are if you have a healthier person versus someone with a lot more comorbidities, what you're looking for in those glucose goals. And even if you have someone that maybe is really like end of life and doesn't have much longer to live, you want to prevent hypoglycemia and you also want to prevent symptomatic hyperglycemia. And so even there may be situations where you say, we're going to do like a once a day long acting insulin so that we can keep the glucose ideally between like 100 and 200 so the person's not symptomatic. And so insulin can be very effective at that. And then it's just the mealtime insulin, I would say, is when things it's harder. And some people, they still need it. But I think it's always about reevaluating what those goals are and not just A1C, because A1C can also be skewed for a lot of different reasons. And so I think our guidelines do a good job of emphasizing using CGM when we can, like also looking at time and range and reevaluating what those goals are, and then trying to back off therapies so that it's easier for somebody and they're not having side effects.
Yeah, it does mention as our adults get kind of older and more complex, we've moved from an A1C of maybe less than 7 to 7.5 to more like a less than 8 or 8.5. But you mentioned if they have anemia, their A1C may not be accurate. And then the time and range, we might go from a goal of time and range of 70% to 50%. Or just our goal might be, avoiding hypoglycemia and symptomatic hyperglycemia. So goals change for sure. But
I do want to emphasize that drives me crazy sometimes is that someone will see someone and they'll be like, oh, they're over 65, A1C goal, now it's less than 8. Well, wait a second. Okay, let's look at the whole picture, right? So if someone they're on no drugs, they're only on metformin, why are we saying less than 8? And I think sometimes we aren't doing enough, especially if you've got someone 65, like healthy in front of you. Like, why wouldn't you want to go lower if you can do so safely with non-insulin therapies? We've got our SGLT2 inhibitors or GLP-1 agonists. Like, why wouldn't you want to do that? So I think also we need to keep that in mind, and also that a lower A1C isn't bad. So let's say you use these drugs, you use the GLP-1, use metformin, SGLT2 inhibitor, their A1C, it goes below 6.5, it goes below 6. Well, if they're not symptomatic, if they're not sarcopenic, like they're actually able to further reduce those microvascular complications with a lower A1C. So if this person in front of you still has many, many more years ahead of them, like, why not? Why wouldn't you want to reduce those, assuming they're not having side effects? So I think this is where the shared decision making comes in. Having that conversation, asking the person what's important to you. If someone says, well, my goal is to get off medication, all right, we'll try to get you off, right? But if someone says, well, I want to avoid any diabetes complications, I don't want to have neuropathy, I don't want to have kidney disease, why not use the therapies and get an even lower A1C? So that's my
absolutely agree. I'm so glad you mentioned that. I couldn't agree more, because it does amount to quality of life at the end. And if you're 65, you might live another 30 years. So let's drop that goal a little bit if you're able to, and prevent, other complications down the road. So this has been awesome. I always learn so much from you. Thank you so much. If you want to find Dr. Isaacs, you can find her on LinkedIn, diabetes-pharmacist.com, the Diabetes Dialogue podcast. What am I forgetting?
Yeah, no, that's all good. Yeah. So Diabetes Dialogue. If you look for that and my name on any place you find your podcast, you should be able to find that. And then also we have video versions on hcplive.com.
Yes, check them out. You'll learn so much. Thank you. Appreciate it. And Happy New Year, everybody.